concept of iPEDENDO has been there for quite some time, because we have been trying to solve problems in a easy fashion, so that we are able to really identify and evaluate complicated pediatric endocrine problems in an appropriate fashion. Number of approach pathways which will allow you to approach to a particular endocrine condition, manage pathways, calculators, diagnostics, therapeutics, and knowledge bank. So it's like, how does it work? We have got 31 approach pathways, which basically covers every condition that you will encounter as pediatric endocrinologist. We have got around 13 management pathways which cover the various possibilities. And when you talk about these pathways, they actually look simple when you solve them, but they are actually very complicated algorithms. So there are various weightages which are given to different situations, so that we want to select the lowest resources required to reach a diagnosis. So if you want to evaluate for growth failure, we would like to keep IGF-1 at the end. If you want to evaluate for some complicated calcium disorder, we'll keep calcitriol at the end. So the algorithm is designed so as to ensure that it is resource appropriate and the cost-benefit ratio is there in that situation. Then we provide personalized, prescriptionized management, and we'll discuss that all throughout that. Now, it basically is a very simple user interface. You just go to the disorder you're looking at, and then you answer a few questions. Yes, no, you will get the answer, and we'll go through about that in that situation. Now, this is available at both the Android as well as the iOS platforms. You can just go and download from there. All you have to do is to register. You will have a free access for 7 days for the entire app, in which you can look through. After that period, you will have access to specific things which are essential, like growth interpreter, like DK. A few of them will remain. Others are for a very nominal subscription in that regards. Now, many of these courses come bundled with their subscription. So if you take the course, automatically the bundle becomes from there. Just to go through a bit, the approach pathway basically uses evidence-based algorithm approach. And the way it is that you have to choose a condition. So suppose you want to approach delayed puberty in boys, you will answer a few questions, and all these are taking you to one section of algorithm. Now, there will be around 100 possibilities which are there, but you will reach, like in this case, we have reached 17 beta HSD deficiency. So it will end up at a particular diagnosis. Now, this is counterintuitive, but this is going to be quite helpful in reaching a diagnosis when you don't have access to expertise, which is not there everywhere. The management pathways similarly use the algorithmic approach. So like if you have hyperkalemia, it will ask the level of potassium, ECG changes, and it will guide you through with emergent management. So all your protocols are pretty much there. You don't need to go ahead and read it, and we give information specifically about doses also if it's required at that point of time. The diagnostic sections was developed largely by Dr. Riddhi, and it provides extensive information. So if you want to prescribe a test, it will give you all the information which is relevant, and every single test which is there in pediatric endocrinology is provided there, along with ranges which are difficult to find often in that situation. The therapeutics by Dr. Sajili has around 64 drugs used in pediatric endocrinology. If you want to know about any in terms of doses, indications, contraindications, you will get all information about a particular drug. Like for desmopressin, it provides this information. So, which will basically be about the sodium disorders. So when you talk about sodium disorder, what we need to remember is that the sodium level depends upon two things: the tonicity as well as the volume. Now, which is the major regulator of sodium level? Is it the free water, or is it the serum sodium, amount of sodium? It's actually the water. So most causes of hyponatremia are because of high free water, while most causes of hypernatremia are because of less free water. So free water is more important than the sodium level, and this is important to understand. So whenever you have somebody who has a sodium disorder, there is a problem in which hormone? ABP. If you have any cause of hyponatremia, you will have to have a high ABP. This high ABP may be appropriate or inappropriate. Even if you're talking about adrenal insufficiency, hyponatremia is not just because of sodium loss. Major hyponatremia is because of a secondary high ABP because of hypovolemia. And that is why if you have zero aldosterone effect in a aldosterone deficiency or resistance, you will have lesser hyponatremia as compared to a combined cortisol defect, because there your ABP will also become high because of cortisol deficiency. So remember one thing, most cases you will have problem of free water than a problem of sodium. Now, if you talk about hyponatremia, free water excess could be a fluid overload or excessive amount of SIADH should be the most important thing, and some hormonal abnormalities. Now, how do you differentiate between a free water excess or a sodium deficiency? Volume will be the key. So the most important thing to look at in a child with hyponatremia is the volume. If it is high, it means that there is extra cellular fluid. It will be liver disease, renal failure, and all those things, nephrotic syndrome. If it is hypovolemic, then you start thinking, okay, this is a loss of sodium, so it could be a GI or a renal loss. While if it is euvolemic, it is usually a SIADH or a hormone deficiency. And hormones play an important role in that regard. Now, we have a regulation of thirst and urine output, which will basically decide about how much is your fluid status. Thirst basically is how much fluid you take and then how much you excrete from that perspective. So if the tonicity in the body increases, you will have a release of the AVP under the influence of the organ vascular lamina terminalis and subfunicular organ, and this AVP will basically cause decreased water excretion. So it will compensate for that process. Which is the major regulator of the volume? And volume depends upon sodium. So it's a very interesting thing. The osmolality depends upon water and volume depends upon sodium. So osmolality is controlled by AVP, which is actually working on water, and the RAS system controls the sodium, which controls the volume. Now the RAS system will basically do a barter. You want more sodium, you have to lose further positive ions. You have to lose potassium, you have to lose calcium, you have to lose magnesium, you can lose protons. So if you have aldosterone excess, you will have hypokalemia, hypomagnesemia, hypocalcemia, metabolic alkalosis. If you have aldosterone deficiency, you will have hyperkalemia, metabolic acidosis. You will also have some change in magnesium and calcium, but mainly and hypercalcemia, because hypercalcemia is also a feature of that. So RAS is basically mainly we are talking about sodium, potassium, but it is also having an effect on other positive ions in that regard. If you, however, have too much volume, there is a third mechanism which is there to cap it up. This is the atrial natriuretic peptide, which says, okay, too much water, get it out of the system. So if your ANP becomes more, you will lose more sodium in this thing, you will lose fluid, and it will suppress your aldosterone. So these all mechanisms will work together. So RAS and AVP work together, and ANP is a contrary hormone which is suppressive. With this perspective, you will have abnormality which will happen. So conditions associated with aldosterone deficiency will cause hyponatremia with hyperkalemia. Aldosterone excess will have hypernatremia with hypokalemia. Now that hypernatremia will be balanced because you will have ANP which will come. Now potassium, very importantly, is an intracellular hormone. It is basically your serum potassium is not a good marker of the overall potassium status. So this potassium goes into the cell because of the sodium potassium ATPase. And what controls the sodium potassium ATPase? Insulin. So if you have got high insulin, you will have hypokalemia. And this is classical in the treatment of DKA and also the recovery phase of malnutrition. What happens when you have recovery phase? You got suddenly high insulin, and this causes hypokalemia, hypophosphatemia. This happens with anorexia nervosa and a number of other conditions. Now, if you use beta agonist, of course, that will cause this hypokalemia. Now, without going too much, we need to know about two major electrolytes, sodium and potassium. Sodium is affected by high lipid and high glucose, wherein you have a pseudo hyponatremia. Sometimes if somebody is having seizures and you measure the sodium from that arm, that level may be hugely high. So this again is a false positive thing for sodium. For potassium, it is basically an intracellular. So don't use tourniquet, don't use hemolyze sample, don't assess if it is thrombocytosis, leukocytosis, whatever, leukemia, they can all have a high sodium. So anybody who has a high sodium should ideally have a low potassium. So this is like that balance. So high sodium, low potassium, this is RAS excess, any of those cases. Yeah. pseudohyperaldosteronism, you have got aldosterone excess, you have got Liddle syndrome, all those things will have this sort of picture. If you have low sodium, potassium will go up. This is hyponatremia, hyperkalemia. This is classical RAS deficiency, cortisol deficiency with mineralocorticoid deficiency, mineralocorticoid resistance, CAH, all that will cause that. Now, what are the exceptions? So we said high sodium, low potassium. If you have high sodium, high potassium, the condition is 9. Gordon syndrome. That's a very, very rare situation. So Gordon syndrome is basically what? What is the problem in Gordon syndrome?
ENaC excess. ENaC.
So it's not the ENaC, it's the sodium chloride symporter. So it is just the opposite of Gentleman syndrome. So Gentleman syndrome, yes, you are losing sodium and potassium. Here you are gaining sodium and potassium. So this is basically a situation very rare causing hypernatremia with hyperkalemia. Which condition will cause hyponatremia with hypokalemia? This is easy. Diarrhea. Yeah. What else? RTA. RTA, yes. Tubulopathy, Bartter syndrome, Gentleman syndrome, and diuretic. We saw so many patients, we get adult referrals, they are all hyponatremia, hypokalemia because of diuretics. And Bartter, Gentleman are diuretics only, basically, if you look at their pathophysiology. So this will be a tubulopathy sort of a picture which can cause this in that setting. So now in hyponatremia, the most important thing to look at uric acid, because uric acid is a marker of volume. The higher the volume, you will have lower the uric acid, lower the volume, higher uric acid. So if you have got fluid overload or SIADH, your uric acid will be low. This is a good pointer to look at, because uric acid excretion depends upon the volume. Higher volume, higher excretion, lower volume, lower. So volume is inversely proportional to uric acid. This is a simple way to understand. Urinary sodium, of course, should be high if you are losing because of kidneys. Otherwise, it's an extra renal loss. Potassium, you should always have hyponatremia with hyperkalemia. If you have diuretic or diarrhea, you will have hyponatremia and hypokalemia. Potassium will be normal if you have ACTH deficiency or ACTH resistance, because cortisol is affected but not aldosterone. Aldosterone is independent to ACTH. This we have discussed when we discussed pituitary. And finally, hemoglobin is also a marker of dilution. So if your hemoglobin is high, it means concentration, low means hypervolemia. So very important thing is to look at urine sodium and potassium. These two will really be very helpful to classify. So if you have hyponatremia, look at blood sugar, lipids and protein. Fluid status shows hypervolemia, it's fluid overload, cardiac, renal, liver. If it's euvolemic, look at thyroid and cortisol, then it's normal, it is SIADH. If it is hypovolemic, now it is a bit of a thing. So you have dehydration with hyponatremia. Look at urinary sodium. The urinary sodium is low, it is a non-renal. Something else is causing the loss, so GI loss. If it's more than 25, look at potassium. So you have got hypovolemia with renal loss of sodium and your potassium is low. So this is only tubulopathy and diuretics. On the end, the potassium is high, then the diagnosis becomes more complicated. You do renin, aldosterone, and then you carry on from there. So most pediatricians will probably be looking at this fluid overload, most likely SIADH, maybe thyroid deficiency, GI loss, and maybe here. This becomes an exclusive endocrine domain. Further workup is required from that. Now, how you manage hyponatremia? Only if there is severe symptoms will you treat. We had a gentleman with 113, he was fine. We did not give any 3% and he would have died if we had given that. So acute severe, and when we had this acute severe, he have to give 3% saline and only to correct the symptoms. When you say acute severe, you're talking about somebody who is dying, somebody who's having seizures, somebody who's having severe cerebral edema like picture. Otherwise, no role of 3% saline. And if only till symptomatic, do not correct his sodium to a normal level. Just 3 to 5 is good enough to correct. If it is acute moderate, you avoid a bolus. Then you rise less than 6 to 9. If it's chronic, no acute treatment. Do not give 3% saline. You will kill the patient, particularly if there is a liver disease or something like that. Hyponatremia is a rarer picture, but again, it can be because of free water loss, in which you have dehydration or a sodium gain. Very unlikely to be sodium gain. I haven't seen much. The only condition which we have seen is a breast milk related hyponatremia. Now, this could be because of a reduced intake, unlikely loss. You can have diarrhea. Now, ideally, in diarrhea, you should have what? Hyponatremia or hypernatremia?
Most commonly hyponatremia.
No, what is the sodium content of the diarrheal fluid?
More hyponatremia.
Is it more than the serum? It's around N/2, 75. So you should theoretically have hypernatremia. Why do you have hyponatremia? Is because your AVP is very active. And if you give fluid, all the free water is taken up. So the normal response to diarrhea is hypernatremia. And of course, if you make an inappropriate ORS, you will also have that. The reason you have hyponatremia is that you give just dilute fluid, body will take up whatever free water you are giving because your AVP is very high. So diarrhea can cause hyponatremia definitely. Sweating, if it's very, very sweating, you can, but mostly chronic hyponatremia is DI. That's what you should consider diabetes insipidus. High RAS, very unlikely because the ANP will take care of it. Sodium load, very unlikely because kidneys will excrete it. So if you talk about chronic hyponatremia, it is DI. Chronic hyponatremia, it is ID, SIADH. So it's the opposite. Chronic hypokalemia, RAS excess. So it's the other way around. Chronic hyperkalemia, RAS deficiency. So that RAS excess may be responsive to hypovolemia, but that is there. So it may be appropriate or inappropriate. So anybody with hypokalemia will have RAS excess. Anybody with the hyperkalemia, unless there is a kidney failure, will have a RAS deficiency. So if you simply think into 2 into 2 table, AVP deficiency is always there when you talk about hyponatremia. AVP excess is always there when you talk about hyponatremia. Now this is a basic concept. So if you have hyponatremia, look at salt load and diabetes. In that setting, look at urinary osmolality. If you have got a hypernatremia, concentrated blood, the urine should be concentrated. But if you have a osmolality less than 600, this becomes DI. No water deprivation test required. If the response is there, it is central DI. It's absent, it is nephrogenic DI. If you have a urinary osmolality which is high, look at sodium. If it is high, it is sodium load. Otherwise, it's a GI loss or osmotic phenomena. So just simple osmolality will give you a trick in that setting. Now, management again has to be slow over 48 hours. Don't want to follow it very quickly. Calculation, there's a proper formula for free water loss, or look at maintenance and ongoing loss, and then we follow that protocol of normal saline in that setting and give it correction. So this is how we go. Preferably oral. If you have around 70 to 100 millimoles per liter, that sodium is good enough. 120% maintenance, and dialysis in severe cases is what is recommended. So we'll go through a few cases. Pratik, if you can come forward.
Thank you, sir. So we have a 12-year-old boy who was diagnosed with DKI. He had hyponatremia 120 and a very high blood sugar of 700.
So do you think this child has hyponatremia?
So the sodium over here is 121, but very significant thing over here is the blood sugar. Now we know that for every 100 blood sugar, there's an increase of 1.6 of sodium. So we need to correct it. Now as the app shows, if we enter the blood sodium and the blood glucose, it will give us the corrected, So it will give us the corrected sodium, which is shown over here.
So it is 135.6. So this is a normal sodium. It is a pseudo hyponatremia which we are discussing.
So next is a 1-week-old boy with hyponatremia and normokalemia. Now the first important, obviously we rule out high blood sugar, lipids and high protein. Now as we discussed, the most important thing is the fluid status which we see over here. What we saw over here, no dehydration, that means the child is euvolemic. And of course not hypovolemic. So the next few things obviously is an SIDH. Now before ruling out an SIDH, we need to rule out any thyroid deficiency or cortisol deficiency. Over here, as we can see, the blood sugar was low and it was a ketotic hypoglycemia and suggestive of and cortisol over here was inappropriately normal for the low blood sugar with the low GH, suggestive of a multiple pituitary hormone deficiency.
So again, it shows that you have to always keep your eyes and ear open about MPHD in a young child with hyponatremia at that age.
A 3-week-old child failure to thrive in hyponatremia. Now we can see the child has actually gained only 100 grams. He's dehydrated, just shown by the high hematocrit. Urine sodium was 100 and potassium was high.
So what do you think, Narayanan, is the case here? We have a dehydrated child, hypovolemic, high urinary sodium. So we are moving towards the direction and potassium is high. So what is out?
RAS.
So this is a RAS defect. This is the classical RAS defect. Now at this age, the most common cause of RAS defect will be CH. Congenital renal hyperplasia will be the most likely cause.
So very few defects such as CH or hypoplasia or any renal vein thrombosis causing adrenal hemorrhage, etc. We should look into that.
So if you look at blood sugar is normal, there is hypovolemia, urinary sodium is high. So now you're talking about potassium is also high. So then directly you go ahead with the adrenal problem, and this turned out to be adrenocortical insufficiency, and this was CAH as a classical case.
A 14-year-old boy with hyponatremia. It was seen that the child is euvolemic. He had a high urinary sodium with the urinary osmolality 300, which is slightly higher. And SAIDH was diagnosed and the child was on fluid restriction.
Do you agree with SAIDH sign? This is euvolemic. It looks like SAIDH, but you have to exclude cortisol deficiency before that. Otherwise, the child will become sick. So this child was found to have a inappropriately low normal amount of cortisol for this level. So this again was a MPHD. So always exclude purity deficiency before you diagnose as SIDH.
A 6-month-old girl who was initially labeled as cystic fibrosis. Why? Because she had failure to thrive, frequent chest infections, sweat chloride was 120. But however, there was no steatorrhea, and electrolyte evaluation actually showed she had hyponatremia but associated hyperkalemia as well.
So can this be cystic fibrosis?
So usually they do not have such high hyperkalemia, so we need to look into it further.
They will have hypokalemia because they will be losing potassium as well.
So as we can go, if we go by the algorithm, the fluid status is hypovolemic, she's dehydrated, but even high urinary sodium is there, but potassium here is high. So suggestive of some sort of a RAS defect. And in this, it was seen that the renin and aldosterone is high. So which somehow goes against the RAS defect, but then the next point is then you can see urinary sodium which is high, suggestive of urinary loss. And so this case actually was a PHA type 1, which mimics cystic fibrosis in many cases.
And this is a systemic involvement. So you will have a problem in the pulmonary secretions also, and that's why you have recurrent infections. You will have skin problems, so your sweat chloride will be falsely high, and you will have milia or rashes will also be there in the skin.
A 1-month-old boy with history of reduced feeding. Now the birth weight was 3100 grams, increased only 100 grams, hyponatremia at 124 and hyperkalemia is there. 17 HP is just fine, cortisol is high. Now PRA is high and aldosterone is high. So
what do you think is this case?
So we have both the high levels are there. So if we go by the algorithm over here.
So it talks about normal glucose volume is low, sodium is high, potassium is high, cortisol is normal. So this
again hypoaldosteronism.
But what is there in the next 3 lines is very important. It talks about excluding obstructive neuropathy, because that can be a form of a transient pseudohypoaldosteronism. So anybody who has hyponatremia, hyperkalemia, you diagnosing pseudohypoaldosteronism, this could be a transient phenomena, and this will improve with treatment of infection.
And also, if there's urinary obstruction, is very important. You should do an ultrasound to rule it out. Your urine routine showed more than 100 UVC, suggestive of infection. And an obstruction was seen over here.
And this is across ages, so not just in the newborn period. We have seen in older people also similar picture. So this is again a very challenging situation. How do you calculate the amount of fluid and which is given? These are the various formulas that you have to look into. But what we have done is that through our app, we have given a very simple measure. All you have to do is to put the weight. You put the amount of sodium that the child has, the desired rate of correction you want to do, and what sort of fluid you would like to give, whether you want to give, and you will get the exact fluid rate. And all these calculations are part of this equation.
Now coming on to a 3-week-old boy with failure to thrive, has lost 300 grams. exclusively breastfed. Sodium is very high at 182 millimoles per liter. Urine osmolality is very high at 1000
So
milligrams.
this is DI, Narayana, do you think? For breast. Why is it not DI?
So the urine osmolality is thousands.
Yeah. So this is basically an appropriate response. Dilute, concentrated blood, concentrated urine. This is not DI. This is basically a breast milk related hyponatremia.
Yeah, urinary sodium was high. So this is seen in very commonly in primary gravida mothers and who don't know the proper adequate feeding, and hence we should check the weight at every 2 weeks and 4 weeks.
So this is more like an exogenous sodium load or breast milk hyponatremia.
A 3-month-old girl with altered sensorium, sodium is 170 and potassium is 4.2. Urine osmolality is 110, so which is low for the high sodium.
So you would like to do water deprivation?
That would be like an absolute contraindication because we have an altered sensorium.
Already a drowsy person who is dehydrated, if you do water deprivation, will die. So there is no role of water deprivation here. You just give a AVP response.
She was advised to have driven, went into seizure eventually, so we wanted to prove the point not to do that. A 13-year-old boy with encephalitis on ventilator support started suddenly developing higher polyuria 10 ml per kg per hour. It was seen that he has 180 millimole hyponatremia.
So what has happened to him, Sayan?
So this is probably a injury which from which the child can't recover, which has involved a large area of the hypothalamus as well.
So this is like a brain death DI, what we call. This is a very, very bad prognosis marker overall.
So post AVP it was seen that it was slightly improved, which is proving the point of the brain death.
So again, the same equation for hyponatremia, we have put forward a very simplified version. So you can just maybe show that if you just put the weight and the amount of sodium which is there, the levels and the desired rate of sodium, whether you want to use a normal saline or half normal saline, you will get the exact amount of volume which is required.